I think there are challenges in developing pain and palliative care programs both at a community level and at an academic level. They differ in many different ways. It may be easier at a community level to develop palliative care because most palliative care initiatives have twinned with existing hospice programs, which are grassroots movements of individuals who have wanted to take back the care of the seriously ill and dying, provide them with adequate pain relief, provide them with quality of life, provide them with, a context of care within their community. So communities have enormous strengths, but this grassroots movement grew up outside the academic community. So the academic community has now moved to develop palliative care programs within hospitals. And I must say that if you're in Britain, or if you're in Australia as examples, there's no distinction between whether you're getting active cancer care and you can also be getting hospice and palliative care. In the United States, because of a hospice benefit, this has arbitrarily separated this out. So if you're getting hospice care, you can't really get concurrent active therapy in most places in the United States based on the Medicare benefit. So the development of palliative care in the United States has been a little bit different because it's focused on the academic community. But I think, again, the good news is that there's been this incredible consensus with the palliative care leaders and the hospice leaders to join together and to form a coordinated system where patients who are cared for in academic centers can be transferred to hospice programs. And those who are in hospice programs can benefit from some of the research that the academic institutions are doing to advance quality care for patients with serious illness. So we've seen a really nice blending of the academic issues and of the community issues. In all of that, there's enormous challenges, and the challenges are that there's not enough doctors and nurses to do this work. There's not enough individuals who are trained properly or are certified to do the work. And although at least in the US the resources are available, if we move internationally, palliative care is not written into the healthcare policy of many countries. So for example, Uganda has written it into their healthcare policies. Rwanda has written it in. Hungary has done that. Romania. So we have individual countries that are low resource that have put palliative care in their healthcare policy. But we don't have sufficient amount of palliative care embedded in national health strategies or national cancer control strategies to be able to say that that's not our big challenge. That is funding it, getting the government behind it, getting the government to support education and training.